Okay, everybody, here we go. Now, we've got some exciting stuff today. Between now and lunchtime, when there will be even more food, we have three main things on the agenda. One, research updates. We have got a pile of medical updates. There's a lot going on in this space at the moment. We've seen the expertise there. We're moving on to Tyler Jarman, who's going to talk about his journey and his situation at school right now. And we're going to, just before lunch, we're going to have a talk about the SSI Community Youth Mentoring Initiative, after which you'll have a chance to talk to the youth mentors themselves. So, a bit of an introduction. We're all good? Everyone's in? I think we're there. Now, Professor John Grigg is the head of the speciality of clinical ophthalmology and eye health at the University of Sydney and group leader of the eye genetics research unit at the Safe Sight Institute. So his research interests, because if you've got any medical questions, just kind of remember what everyone specializes in, although they're pretty good at handing to each other, is genetic eye disease, glaucoma management, electrophysiology of the visual system with applications to upcoming clinical trials. That's John. Professor Robyn Jameson is the head of the specialty of genetic medicine and professor of genomic medicine at the University of Sydney. She leads the eye genetics research unit at the Children's Medical Research Institute, the Children's Hospital at Westmead, and the Safe Sight Institute. Her team's genomic and stem cell research is leading to transformational opportunities for new therapies in genetic eye diseases. Dr. Anai Gonzalez-Cordero is the group leader and senior lecturer of the Children's Medical Research Institute at the University of Sydney. She has achieved a PhD and experience in stem cell and developmental biology at the Institute of Ophthalmology at University College London. She's a leader in the field of stem cells and their differentiation into organoids, with an emphasis on translational research to develop novel therapies for genetic diseases. How am I going with pronunciation so far? And finally, Dr. Elisa Cornish is a staff specialist at the Sydney Eye and Westmead Hospital and a senior clinical lecturer of the Faculty of Medicine at the University of Sydney. She completed her medical studies and PhD at the University of Sydney, the latter focusing on the development of the primate retina. Her fellowships in uveitis medical retina and inherited retinal disease at Sydney Eye Hospital. She also underwent highly regarded training at electrophysiology at London's Moorfield Eye Hospital, Ocular Genetics Department, and multimodal imaging experience at Luigi Sacco Hospital at the University of Milan in Italy. So we have got, I'm not allowed to say hundreds of years of experience, that are probably decades and decades of years of experience, and very, very active researchers here. They're initially going to start with a 2-minute quick update in each of their fields, what's happening, and then open field for questions. So who's kicking off?
Hello, everyone. Pleasure to be here. So I work on stem cell research, and stem cells, I like to say that they are these magic cells that we can generate any cell type of your body, right? So what I do is to generate eye cells, mainly retinal cells, and within those, photoreceptor cells, which are the cells that sense the light at the back of your eye, right? And when you've heard us talking about organoids, they're basically three-dimensional little mini retinas that we grow in the dish from the stem cells. And we can get stem cells from patients. And then we have a mini retina that develops the disease in the dish, and we can now study the disease and have that powerful human cell that, you know, is developing the disease, and we can now test drugs, new treatments, and so on. So in my lab, we are interested in testing genetic therapy. So we replace the fault gene into these organoids, and we can say, okay, yes, it's treating the condition or not, or we need to improve here, we need to do this at this dose, or and so on. Another big part of my lab works on cell therapy. So now we use healthy mini retinas, and we can isolate the cells from these mini retinas. So for glaucoma, we would isolate retinal ganglion cells. For inherited retinal degenerations due to loss of photoreceptor cells, we would isolate the photoreceptor cells. And we've been doing it for 10 years now, where we isolate the cells and we transplant it back into the blind mice. We still at rodents kind of stage, so very not early, mid-stage research, and we've seen very promising results with cell therapy. And cell therapy, you don't need to worry about the specific mutation, so it's more of a universal therapy, transplanting the healthy cells back into the eye. And I think one update that I have is that we received a large governmental grant where we're now moving this technology to good manufacturing practice, so we can produce these cells in a way that they'll be suitable to be used in humans. And that's what we are progressing towards now. So yeah, that's my bit. Thank you.
So hello, everyone. It's great to be here yet again, another year, 11 years, pretty good. But it's wonderful to be here and to be able to let you know where things are up to in the genetic eye disease research space. So we're really focusing now on, because of there's incredible amounts of new technologies coming through, and really good places that we want to be in terms of delivery of gene therapy delivery, or pharmacological therapy deliveries, or subsequently stem cell therapy deliveries. We're really wanting to ensure that everyone across the state or across Australia, has had the opportunity to have a genetic diagnosis, if that may be possible. And so we've really implemented what we call an ocular genomics multidisciplinary team approach as a virtual approach, so that even if a person lives in the country and they might see the genetic service, which might be an outreach genetic service or another ophthalmologist, that information can be brought to our virtual team, and so that then that can be sorted out, and we can have people in the right understanding about what is the genetic diagnosis, and then what are the steps that we need to take forward for that. And sometimes there are a number of different steps that we need to take. Sometimes the genetic diagnosis is clear cut, and so that's good. And then potentially there can be research studies to work on the particular genetic aspect that we need to develop the gene therapy for that gene, or pharmacological approaches, which we do in our lab, and also, as Anai mentioned, is happening in her lab as well. So we do work as a team in this kind of approach, so that, because this is an enormous problem. We have over 200 known disease genes, and that's only in the inherited retinal diseases. And we'd love to get on to other conditions as well. So there's an enormous issue here, and we obviously work nationally and internationally to make sure that we're all working together in that space. But then, so we need to have that approach. Sometimes there's variants of uncertain significance. Sometimes there's a clear-cut genetic case, but sometimes there's variants of uncertain significance. And so we need to have the scientific approaches happening in that regard, because then we really want to have this genetic diagnostics happening for as many people as I said, because when we come to clinical trials, what's happening is we're getting contacted by international agencies, but then they want to know, well, what's your patient group? How many patients are there in Australia with changes in that particular gene? And so these tend to be rare diseases, so can be fewer cases. So therefore, we're in a stronger position if we know who's got those particular changes, so that then we can attract the clinical trials to be able to get help for people as far as possible. So that's where we're up to. We did have a publication actually in the Medical Journal of Australia, which was a big breakthrough this year, looking at the costs of vision impairment for people with genetic eye diseases, particularly in the retinal space. And the reason that we've done that work is to build the case, because we really need to build the health economic case for when we want to introduce, when we've got a gene therapy or some other therapy that's working, so that we can get that funding and be able to implement that for people across the country. So it's a really active space from the research perspective, and it's really great if you can become involved in that space as well.
Right. So yes, my research is more on the clinical side and the clinical trials and looking for appropriate outcome measures for these trials. So, you know, typical non-inherited retinal disease trials like macular degeneration might have outcome measures such as the vision on a chart or a scan showing that the treatment is working. But in inherited diseases, you know that there's other things that affect our patients. It's not just the reading vision, it's night vision, it's peripheral vision. There's other things that could be tested. And if we can't test the before and after or the natural course, then we can't show that one of these new therapies is actually working. So some of these outcome measures are things like in previous clinical trials have been a maze set up in a room with certain lighting conditions. However, that's not as practical as doing that here in Sydney and someone doing it in Perth, because you've got all these big rooms that need to be exactly the same and the lighting all switched on. So instead, we're looking at trying to develop a virtual reality headset so that it can be easily transferable between different clinical genetic trial set places. And within that headset, there's a kind of maze for the patient or the clinical participant to walk around a room or use their little remote control in their headset, but with their hand to try and avoid a virtual cupboard that's there to try to get under it, or steps to go up and down in different light conditioning, or trying to get on the right bus if a bus comes along and get the right bus number. And I think it's really exciting because this is, you know, a way to measure things that are more real life rather than what's a vision chart on the wall. So that's just what we're doing at the moment.
Thanks very much. So I'm in the clinical space, and really, I suppose the clinical research is now weaving the basic science into that as we're now moving from the diagnosis, as Robyn's talked about, and the work that Anai is doing, and Lisa, into sort of the clinical trials. And this is really bringing sort of two parts. We have to have the diagnosis at the start, and we're trying to shorten that journey. We've heard Michael talk this morning about the long journey it took for him to get there. I think we're getting better at that. And then we're also then looking at how we can sort of get as many people into these therapies. And so that brings, we need to have an accurate diagnosis, and then we have to have the tools to do the therapies. And we've had 3 clinical trials have just finished recruitment. And so they're starting to progress on these for Stargardt disease, 2 of them, and one's for Usher syndrome, which is a type of retinitis pigmentosa as well. That's just finished recruitment as well. And we've got approaches from 3 other companies at present for different types of retinitis pigmentosa, particularly X-linked retinitis pigmentosa and achromatopsia type of extreme light sensitivity. So there's sort of, as we finish one lot, we're moving now into 3 other ones that are coming. So all the things we've heard this morning, in a way, sort of all combine to enable us to deliver this. And I suppose that's where we really need all your cooperation as well to help sort of progress this along, because it does take a lot of work to, I suppose, convince both regulatory authorities, governments, and then the companies to all come and do this. So I suppose on that note, we'll then open up the floor for some questions.
Right. So I've got a list of questions here that pretends to be 5, but it looks like it's actually squeezing more questions in. But anyone can ask whatever question they want. I think we have our first question from the floor. I will repeat it just in case. No, we can do that at the end. I know exactly when. So that's
okay. I would love to know about the work about NAT1. Yes.
Hi. Yes. So I did actually have a quick peek at the questions before, and one of the questions was where are things up to with retinitis pigmentosa? And I guess the point to make is that, as I mentioned before, there's many different disease genes, and there's different disease genes for retinitis pigmentosa. Disease gene meaning a change in a gene that actually causes the problem. So for retinitis pigmentosa, for instance, and all of the retinal dystrophies together, which includes then the cone dystrophies, the cone rod dystrophies, Leber congenital amaurosis, Stargardt disease, Usher syndrome, all of them together, there's over 200 different disease genes. And so to have a specific gene therapy for each of those genes, as you can imagine, is then an enormous task, because each one of them, so in clinical therapy at the moment, we have a gene therapy for one gene. That's the RPE65 gene, and that's the Luxturna gene therapy, which is now clinically, publicly funded and available in Australia, which is an amazing breakthrough. And we've treated in New South Wales 6 patients to date, but that's only one gene, and we've got over 200 to be working on. So you know, there is an enormous task ahead of us, but nonetheless, NEMAT1, the NMNAT1 gene, is one of them. And we do know that there's a group in the States that has got a gene therapy for that particular gene that has shown good effect in a dog model. When we were there was an international meeting in the States earlier this year, and there has been, part of the problem with this is that these are rare diseases. And so the big pharma doesn't want to take it on because they don't think that they can make a lot of money out of it, sadly. That is the commercial reality. However, there are others of us who are in the world who, you know, are interested in this because, you know, of course we want to make a difference for patients. There has been a philanthropic company established in the States, which is then trying to work on trying to get support for some of these rare conditions so that they can get them into clinical trial. So that's where NEMAT1 is up to. It's in that area. And so that's what I was kind of mentioning about. We need to know about, you know, as many patients as we can in Australia, because if we're going to attract a clinical trial in that particular space to Australia, we need to have the patient numbers. And so that's why, you know, there is a push on now, I think, that people get their genetic diagnoses so that we can be in a better position to take that up. So that's where NEMAT1's up to. And there are a number of other individual genes that are in that kind of space as well. So there is work happening.
So gene therapy is real and it's now part of the system. And if you go and get genetically diagnosed for exactly what you've got, that's actually contributing towards a public good, because that gives the data we need to get the funding to cover another 199 therapies and beyond. Okay, we got it. Now, I've got another question here, but does anyone want a question for? Aha, we have a question.
I'm Megan Pritchard from Cataract Kids Australia. I'm really excited to hear about lots of progress in retinal diseases. I wondered if you're aware of any relevant.
Childhood cataract update.
I suppose there's 2 components to that. There's the modern treatment of that, and understanding then that in childhood cataract, it sort of falls into probably about 60% of those are due to a genetic change, and about 30% may be due to metabolic and other sort of conditions. And of the childhood cataracts, probably 40% or 50%, between 40 and 50% are unilateral. And so that's where the genetic changes occur twice in that one eye. And so you can often not affecting the rest of the body. The advances have come in the management of that and trying to preserve vision over time. And where we've found is that the timing of cataracts is important. When you do the surgery, it has to be visually significant. If you've got cataracts, we try and push it out sort of beyond between 6 and 12 weeks because other complications occur. In fact, we just published our results last week on the last 20 years. And so with modern techniques, we've reduced sort of the risk of glaucoma over that period of time from 16% when we published that 15 years ago now to down to 13%. So a small change, but does mean a significant change. But I think the genetics of this has improved a lot, and perhaps Robyn can comment on that, because that's been an area that's a lot of work has been done as well, trying to understand the recurrence risk there.
Yeah, so if people are interested in genetic diagnosis in cataracts, so we have actually worked in that space. So cataracts, as congenital cataracts, as well as anterior segment dysgenesis, so ocular anterior segment dysgenesis. So congenital cataracts can be part of that, and also developmental eye disease like microphthalmia and anophthalmia. We've worked towards getting genetic diagnostic panels for that and availability on the public health system as well, because as people may or may not be aware, genetic diagnosis is not Medicare funded actually. So that's the other reason for doing the health economics work, so that we can have arguments to government and the Medical Services Advisory Committee that, you know, the genetic diagnostics is worth doing, because, you know, amazingly, it is not publicly funded still. But we are fortunate in New South Wales that, so what I mean by that is it's not Medicare funded. So it's not nationally funded, which is really annoying and bad from an equity point of view across Australia. But fortunately in New South Wales, we're in a situation where New South Wales Health will support and pay for genetic testing when it's clinically indicated, you know, which is the majority of cases, if there's genetic eye disease in the family. And that's the case for congenital cataract. So we are able to get that on the publicly funded system. Also the anterior segment stenosis, also the microphthalmia and ophthalmia. The problem with them is that if you aim to get a genetic diagnosis in those conditions, the detection rate is probably around about 60%. So there's still going to be probably about 40% where we don't know the answer. So we do still need further research in that space. We need to still find what are the other disease genes. We've still got all these problems of variants of uncertain significance, as we have with the retinal diseases. And so we would, you know, there is a need for more research in the stem cell space actually as well, to be differentiating to those particular tissues as well. So there's lots of opportunity for research in these spaces, but I think, you know, there is progress that's been made, and they would also help then in the therapy areas, because then we'd have a model system to be able to manipulate, to test other drugs and so on and so forth. That's helpful.
I'm going to throw a question in that we had a quick chat about 15 minutes ago. Where do we go for data on incidences of VI in Australia to inform the education system about needs? Interested in CVI, BBVI, and if there's any trend. Word of mouth is fine, not anything concrete. So if we start on where do we go for data on incidences, I think there is a national vision impairment register. So anybody who has a child with vision impairment is meant to be found by the system to add yourself to the database. And this has been running for a number of decades. That has been run by, I think it's Next Sense of Dr. Sue Silvera and oh, sorry, what's the Renwick Centre
through University of Newcastle.
We've actually had a chat to her this year, and she is actually very open to presenting on this topic. Unfortunately, she had a clash this year, but our goal is next year to have a bit of a deep dive into that. So that's kind of come along next year. Is there anything else we should add? And then the second part of that question was interested in CVI, BBVI, and if there's a trend, word of mouth, anything on that space that you've...
Well, CVI is now termed cerebral visual impairment, and that's probably the commonest cause of vision impairment in the first 2 years of life now is multifactorial. Prematurity is a high risk factor. Other infections in that time is also, or other developmental issues. We've just, it hasn't come in press yet, another publication that has looked at all the causes of vision impairment or reasons why children present to the Children's Hospital over a 6-year period for under 3s. And that's coming out as one of the major causes of lifelong vision impairment. So, and it's a difficult condition to diagnose.
So there's work on that space. It's important. Now, I've got another question here, but anyone have a question at this stage I want to put? Right. Now this is kind of topical with what you were talking about before. How has funding of research in visual impairment changed from a government side of things in the last few years? Is it more streamlined since genetic testing has become so advanced and relevant to society? I've somewhat touched on this, but you're having to interact with the system. How's it changing?
Yeah.
Well, I can talk on the stem cell side. I'm very fortunate because I work in vision, but the stem cell, it's quite a hot topic at the moment. So we do have specific funding for stem cell and I can tip into that, I guess, a little bit more. There's functional genomics funding, but vision specifically, we are missing a big government. Am I right to say that? I think we are missing a big governmental grant that will really fund visual research specifically. We try and get our hands in different pots, as I've been mentioning, in stem cell functional genomics, because we do research in that area, but we're trying hard to push towards that.
I could just, yeah, I was just going to mention then on and then in terms of public funding for genetic testing and genetic therapies, you know, we have touched on that briefly, but that's where the health economics work really comes into it. And also, we're also working on other what's called implementation science research, big name, you know. But what it's basically about is trying to understand then what are the problems in the system, in the health system, that are barriers. Because there has been a genomics revolution, and sometimes the health systems and so on haven't really kind of caught up with that. And of course, there's a lot of demands on the health system for all areas of medicine and so on. So, but, you know, there is a genomics revolution, and there's been a lot of problems with trying to implement that as much as possible. And then that's partly to do with education, as well of medical providers and other healthcare professionals and their understanding, and then also the whole system aspects of the health services providers and understanding that there has got to be funding for that. So we are implementing a health implementation science research project, and Dr. Alan Ma from our team is leading that, and that is going to be looking at so what do the patients say? What does the community need? What are the issues? What are the blockers for the people trying to access the services? What are the blockers for the medical professionals or the other healthcare professionals, optometrists and so on and so forth, to helping people with vision impairment and where they need? And what are the issues? What do the health service providers? What do the heads of hospitals and, you know, public health systems need to understand about the costs and so on of vision impairment and the issues, so that we can make these systems better, and then that will then feed into applications for, you know, national funding, both for the diagnostics but also for the gene therapies, because then of course the gene therapies themselves, so we've had to implement a whole different system of delivery of so Luxturna, for instance, the first P65 gene therapy, that was it's got an adeno-associated virus, which is the delivery system for the gene. Well, that's a whole nother level of implementation within the health system to get that happening. So there's many sort of systematic factors as well, and system factors that we need to overcome. So that work is happening. So you may get contacted about the health economics research, but also the patient experience type of research. And I know that there are surveys, and I know that it's incredibly tedious and very time consuming, but I guess I want to, you know, we want to let you know about it because that, you know, that's important, and your voice is important as part of these processes as well.
So if we're at a event that has a local politician in it, we should, the more often they hear it, the better.
That leads nicely what I wanted to contribute as well, because I think if you look at the amount of funding that goes to medical research in Australia compared to OECD, if we compare to what's funded in the United States, so their National Institute of Health, NIH, you've probably heard of that, they get $45 billion a year. In Australia, our population, we're a 13th of that. So we have 1.5 billion currently in medical research. So that's 1 billion in the NHMRC and about $500 million in the MRFF. This is figures from last year. So if we take a 13th of the US funding, we should be funded about $4.5 billion. So we're sort of a third underfunded in this country. if you look at the National Eye Institute, which is a subsection of the NIH in Washington in the US, they get $900 million for vision research each year. We get $15 million in Australia. So we should be 3 to 4 times that we've worked out, we should be getting $65 million. And if that was spread across the country, we'd have a lot more advances more quickly. I mean, Australia does extremely well in vision research. I mean, the work you've heard from Robyn and Lisa and Anai is really world leading. And people ask, you know, should we go overseas for things? Well, it's happening here, right here in their labs and in other centers around the country as well. But imagine what we could do if we had that extra funding on parity with other OECD countries. And so if you're at a function with your politician, then that's what we would argue, that we need 4 times the amount.
Add to them, you know, you drive past their office, they've got the big signs with their face all over the window. Drop on in, just say hi.
I suggest if there was a 1 or 2 pager that explained that, I'd be more than happy to go to our local member and say, hey, we want your support. And I'm sure, you know, if we had a whole bunch of people doing that, we could reach like 20, 30, 40 politicians, right?
So the call out is for a nice, simple elevator pitch document that we can carry into our local member's office. Sounds good. So we've got a call to action there. We're going to take that down. Now, one thing I'm noticing actually is, if I reflect back when 7 years ago, when my daughter was born, she's blind, and I started paying a lot more attention, it was very much, the conversation was very clinical, very early stage, very theoretical. And I've noticed that we've started talking about, you know, now we're at rat models, now we're at dogs, now we're at human beings, now with Luxona, we're talking about, hey, it's now on the list. So I suppose if we think not in terms of kind of initials and acronyms, in the world of doctors and therapies, where does it feel mainstream now? Where does it feel that now it's got to a stage where either it's right on the cusp or it's like a doctor now knows who to refer to and something can be done that previously was just, it was in the lab?
Okay, so I started my training not 7 years ago, but close. And at that time we were saying, I'm sorry, you've got retinitis pigmentosa. We need to get you to go see the appropriate teams to get your best vision, but we'll see you in a couple of years. And, you know, that's such a contrast to what it is today. So I see my patients, I say, well, first of all, we need to get a clinical diagnosis from the genetics team. We need to know which gene is going on. And even if we don't find out which gene it is, we can then also still include you in some of these clinical trials that are coming. And we have some here and more are coming, and more pharma companies are coming to approach us. So it's a really exciting time.
The revolution is now. This is
Army, man. And
right, all power. Now, do we have any other questions? We're all good. We know everything. We're there. We're fully up to date. That is great. Now, we've got a little blurb. Now, I can tell you, and I had a conversation with Brian over here a bit earlier, that I feel like we're in the future. We're living in the future right now. We're talking about stem cells and gene therapies as real world things that are actually done, not just theoretical. The Jetsons have let me down. We still don't have flying cars, although Brian pointed out to me that if you forget to fill up, there could be consequences with a flying car. We've got Blade Runner-like digital billboards, etc. And we know that there are now hundreds of therapies that are possible. And to bring that future forward faster, we need money. So what can we do? So we've got a little talk right now, just for a minute or so, about how you can help both raising and spreading the word.
Hi, everyone. My name's Anita Hancock. It's nice to meet you. Matthew and I have a 7-year-old Amelia who has Leber's congenital amaurosis.
Get the camera. Shuffle that way so you can be famous.
Famous. Oh, okay. I'll come and sit next to the miracle workers. Stand up here. Okay. How lucky am I? Okay. So what can we do with all this amazing miracle working stuff? We're probably feeling quite helpless, sitting there going, okay, that's great. There are scientists doing amazing work. What can we do? This year, we have been asked by Professor Jameson to be the ambassadors for the Genes for Genes Day charity. Now, I'm not sure if you've heard about it. Most of you probably have, but it's coming up next Friday, August the 4th. So it's a big fundraising day for this amazing work that is happening. The proceeds, if you decide to donate, are tax deductible. They'll go directly to Professor Jameson's lab and promote this amazing, amazing stuff that they're doing to potentially find a treatment and a cure for our blind community. So we are the people that we need to advocate for this because, as they said, they're not getting enough funding. So I'm asking each one of you, if you can please take this cause on, you know, if you can donate yourself or if you can tell all of your friends and family, we'll send a link around, Emma will send the link around. And if you donate specifically to Amelia's fundraising page, you know, there's merchandise to buy and stuff, but if you donate specifically to this link, it will go straight to Professor Jameson's lab and they can keep doing the amazing work that they're doing, but they need our help. They need funding to promote what they do. And so this is something that we can really do that's practical. Tell all our friends about it. It'll be on the TV on Channel 9, fundraising for the Genes for Genes fundraiser. So please, August 4th, everybody, if you can, make a contribution and tell everybody that you know the money is going to go straight to this amazing team. Thank you.
Remember, share it to your network. All of you have got a lived experience, which is why you're in this room. People give if you tie it to your lived experience. Go for it.
You're looking for businesses rather than individuals to sponsor. Is it the same link?
Yes.
Yes.
Thank you.
So business, if you know a business that'll give, same link. Businesses can give too. If they want to give millions, that's fine. Tax deductible. There we go. All right. Anything else we want to do to wrap up? We're good with the research panel. I think that was very inspirational. I think we're there. We've kind of landed, and only 199 more therapies to deliver. Thank you very much. Much appreciated. Okay. Could we have a round of applause?